Hi, this is Dr. Abir and we will be discussing stomas in detail today. By definition, the term stoma is usually applied to an external opening, temporary or permanent, in a illuminated organ. Types of stomas. Gastrostomy. Either a surgically created or endoscopically formed connection between anterior stomach wall and anterior abdominal wall, often for stomach drainage or direct feeding. Jejunostomy, either a surgically created or endoscopically formed connection between proximal jejunum and anterior abdominal wall, often for direct feeding. Ileostomy, formed from any part of mid or distal ileum, may be loop, often to rest the distal bowel, or end, usually as a result of surgical removal of distal bowel. Colostomy, formed from any part of large bowel, may be loop to rest the distal bowel, or end because of surgical resection. Urostomy, formed from a short length of disconnected ileum into which one or both ureters are diverted, usually after radical lower urinary tract surgery. Some specific typical features that may help identifying the stomas are as follows. For gastrostomies and jejunostomies, these are narrow caliber, flush with little visible mucosa, and are most common in upper left quadrant of abdomen, fitted with indwelling tubes or devices. Ileostomies, loop or end, are usually spouted, have prominent mucosal folds, tend to be dark pink or red in color, and are most common in the right side of abdomen. Colostomies, loop or end, are usually flush, have flat mucosal folds, tend to be light pink in color, and are most common in left side of the abdomen. Urostomies, end, are usually spouted, have prominent mucosal folds, dark pink or red in color, and are most common in the right side of abdomen. These are indistinguishable from the ileostomies unless output can be seen. Now let's discuss preoperative stoma planning. Depending on situation, a stoma can be temporary or permanent, end or loop. Regardless of indication, placement and construction are crucial for proper functioning of the stoma. Pre-op marking of the stoma site is essential. Pre-theater planning include counseling of the patient, education, stoma siting or positioning, decision regarding type of anesthesia, blood grouping and saving, single dose antibiotic pre-operatively. The positioning of stoma is very important. It should be positioned where patient can easily see and manipulate, within the rectus muscle, below the belt line, away from the costal margin and iliac crest, 2 to 3 finger width away from the midline incision to provide adequate in-between barrier. A poorly placed stoma can leak and cause skin exfoliation. Deciding the type of anesthesia. General anesthesia is given if the stoma formation is done as part of any other procedure or if laparoscopically formed. Local anesthesia if isolated loop stoma formation. Let's discuss the steps of stoma formation. For all stomas, a circular skin incision is created and the subcutaneous tissue is dissected to the level of anterior rectus sheath. The anterior rectus sheath is then incised in a cruciate fashion, muscle fibers separated bluntly, and posterior rectus sheath is approached. Care should be taken to avoid injuring inferior epigastric artery and vein. The size of the defect depends on the size of bowel used to create the stoma. The stoma should be small as possible without compromising blood supply of the loop, usually 2 to 3 finger width. The bowel is then brought through the defect and sutured. The abdominal incision is dressed prior to maturing of the stoma to prevent wound contamination. In order to make use of appliances suitable, a spout of the bowel is created. 3 or 4 interrupted absorbable sutures are placed through edge of the bowel, then through the serosa, approximately 2 cm proximal to the edge, and then brought to the dermis. This technique is called the Brooks technique. After the stoma is everted, the mucocutaneous junction is sewed circumferentially with interrupted absorbable sutures. This is the final step. The steps here are shown in the picture: skin incision, muscle dissection, bringing out of the gut after mobilization, stoma eversion, and finally anchoring. Now let's discuss the post-operative management and care plan. Post-op management includes pain management, early detection of the complications, stoma care, counseling and education of the patient for home care, diet modification, activity education, fluid requirements, changes of ostomy appliances twice a week, and peristomal skin care. The dietary guidelines post-stoma formation include regular small meals, eating slowly and chewing well. For the first 6 weeks, avoiding diet that causes flatulence or loose stools, for example, beans, broccoli, Brussels, cabbage. Eating food that helps thickening the stools like bananas, bread, and cheese. Adequate fluid intake so that dehydration could be prevented. Eating tender cut meat. Let's discuss the complication of stomas. Early complications include dehydration, bowel obstruction, stoma stenosis, mucocutaneous separation, and fistula formations. Late complications include stoma retraction, stoma prolapse, peristomal hernia, fistula variceal bleeding, skin ulceration, and bowel obstruction. The systemic complications of stomas include stoma diarrhea, nutritional deficiencies including vitamin B12 deficiency, electrolyte disturbances causing mostly hypokalemia, stones, psychosexual disturbances, residual disease. Thank you for watching. Kindly subscribe and like my channel. We will be discussing the complications in detail in future videos.